Hi guys, thank you all very much for tuning in today to hear my lecture on New Horizons in Digital Cosmetic Dentistry. This has been very kindly sponsored by Oral-B and thank you to Denplan and to Dental Update for putting all the organisation in behind the scenes. So this is me, my name is Dr Simon Chard. For those of you who don't know me, I have a practice limited mainly to cosmetic and implant dentistry, but always with a skew towards how we can use digital dentistry and digital techniques to improve workflows, improve predictability, and improve the comfort and efficiency for our patients. I work down in on the sort of border of Surrey and Middlesex at Rothley Lodge Dental Practice that I own with my wife Megan. We have a 7-surgery multidisciplinary practice down there. And in my spare time, I'm also on the board of the BACD, the British Academy of Cosmetic Dentistry. So everything that I'm doing, even though I'm always trying to use digital, I'm always trying to do it with a lean towards making sure that everything looks as beautiful and natural as possible. And then I've also recently co-founded Parla Toothpaste Tablets, which is an eco-friendly toothpaste brand, which we're very excited about, which is going very well. So this is my clinic. This is Rothley Lodge Dental Practice. So as I say, the focus of our workflows here is to use digital as much as we can do. So we've got a couple of Omnicams. We have a prime scan, and you can see on the video there how we make most of our restorations. So I don't really take traditional impressions anymore, and we're making our restorations, our ceramic and indirect composite restorations, probably about 90 to 95% of them made in-house. I'll show you the different workflows for that later. Now, I do quite a lot of teaching on digital dentistry, so I'm one of the main key opinion leaders for Dental by Sirona on their CEREC side of things, and for Ivoclar Vivadent as well from their Emacs and Empress CAD block systems, which I'll talk about later on. And I run a course of everything from beginner to advanced CEREC dentistry at our CAD training center at my practice. And here's Parla. So that's what we've just launched. That's Dr. Rona Iskander and Dr. Adash. Thank you there. And yeah, we've been very grateful to have a really good response from the press on that. So check that out if you're interested in eco-friendly solutions. That's a fully plastic-free product there. So this is what we're going to talk about today. My journey with digital dentistry, an overview of what I view to be the benefits of moving towards digital. If you're not using a scanner already, then I honestly do believe that you will be at some point. It's just when you make that leap into it, because this is the way that dentistry is going. And I believe that traditional impressions will go the way of traditional film in photography, and eventually it will become obsolete for all but the absolute passionate purists. And then I want to show you how we're using it at the practice for various different disciplines. So whether that be restorative, which is the bulk of it, orthodontics, which I do a fair amount of Invisalign as part of my restorative treatment plans, and then also how we're using it to plan and restore our dental implants. So as I say, I started with the Omnicam. I qualified in 2012 from King's, and obviously following finishing my VT, I was very fortunate to go into a few different private practices, and one of them was a practice where they also had they were a reseller of CEREC systems. So that gave me an exposure to digital dentistry very early on in my career. I hadn't had any training on it at dental school, but I was sort of given this Omnicam and told, this is what you're using for your crown and bridge, off you go. And even at that point, which was sort of 7-8 years ago now, the software wasn't anywhere near as straightforward as it is today. So the learning curve was quite steep then. But I was very fortunate to have such a great tool. And as I say, we have 2 of these Omnicams in our clinic now, and one of the MCXLs, which is the milling unit just there. And then last year, I think it was February, 2019, Dental by Sirona brought out the Prime Scan, which is their touchscreen, I believe, still the most accurate scanner on the market. depending on which studies you look at, but from the independent ones that I've seen, the most accurate scanner on the market. And I was actually the first person in the country to have one, and it's an epic bit of kit. I absolutely love it. And obviously Dents by Sirona have recently brought out a new mill last year as well, which I'm sure we'll be getting soon. Now, I do a fair amount of 3D printing in the practice as well. We've got two different types of 3D printers at the practice. One of them is the Anycubic Photon, which is a great bit of kit, to be honest with you. It's only around £400–500 on Amazon, which compared to the majority of the dental equipment that we use is an absolute steal. And if you want to sort of dip your toe in 3D printing, this is a great way to do it, just to see if you're actually going to use the equipment. Because my experience with 3D printing is that there's quite a lot of sort of process and mess involved, and for some people they just can't be bothered, so they'd rather get their laboratory to do it. But it's actually a really good bit of kit to have in the practice. We use it mainly for trial smiles, so I do a fair amount of work with the Digital Smile Design Lab in Madrid, and to save them from sending over a physical model to me, they can just send me an STL file, and then I can print it in-house, which is, from an eco point of view, more sustainable, and also it's cheaper for me as well. And I'll tend to print that out on my Formlabs Form 2, because that's the more sophisticated of these two printers. These two things here, this is the Form Wash, which basically washes away the excess resin with 99% alcohol. And then this is the Form Cure, which cures the uncured resin. And that works very well. Now, I don't really use these printers for surgical guides. And the reason for that is that the surgical guides that I get printed, which you'll see later on, are printed on Stratasys printers by Implant Guide Direct. And those printers, I believe, are sort of a couple of £100,000, which the level of accuracy that you get on those compared to these is dramatically improved. So these are great for models, for digital wax-ups, that sort of stuff, where you want to make in-house whitening trays. You can 3D print your scans and then do a suck down over them. But when it comes to a surgical guide where micron by micron accuracy is vital, I tend to prefer the laboratory to print those out for me. Now, the other technology that we've recently invested in is the EMS Airflow. So this is bringing technology into our hygiene, and this has been received very, very well by both the hygiene team and our patients so far, and I'll talk a bit more about that later on. So let's start with the case here. This is Michelle. Michelle's been a patient at the practice for 35 years. My dad, who's also a dentist and who's owned the practice for that time, did these crowns on her 27 years ago on her upper centrals, and unfortunately one of them has fractured, as you can see on the palatal. There you can see the fracture, and and the other one had secondary caries underneath it. So we elected that we needed to change these crowns over. Now, these are all ceramic crowns. As I say, they've lasted a good 27 years, so if my work lasts that well, then I'll be very happy. But we're going to change these using chairside CEREC same-day technology. So this is the dismantling of the old restorations. You can see a layered ceramic there, probably, I would imagine, in ceram or some sort of a luminous coping there, but not looking too bad. So what we're then going to do is convert these into what I would describe as a milled all ceramic crown prep. So smoothing off all the edges, and we go through this a lot on our training, how to get preparations to be designed to reduce the chance of fracture moving forward and to improve bond strength and that sort of thing. So these are all smooth. As you can see, we've got some retraction cord packed down there, and they're now ready to be scanned in. So we're going to scan the patient in. There's the scan. As you can see, nice clean margins, nice clean scan, hemostasis, all of those traditional concepts, very, very important for digital dentistry as well as with analog dentistry. And I think in reality, the principles of good tissue control, good preparations, all of those things are actually arguably more important with digital. I saw an article from the Spear Group talking about the fact that a technician can kind of get you out of trouble a little bit with when they're doing a traditional lost wax technique for restorations. But with digital, and when you're milling, you've got a lot less room for error. And so bad dentistry will get you in a lot more trouble a lot quicker when you're doing things chairside and with CEREC. So really, really important that the data you're putting in is going to massively guide the data and the restoration that you get out the other end. So here's our initial proposal. This has been designed by the software biogenerically and just sort of tweaked by me, but the software is so good now that I have to do very little work on that. And then we're going to mill this out. So these are going to be milled in Empress Multi, so Empress CAD Multi. The beauty of this is it has a gradient of both translucency and chroma through the block. So although it's monolithic and you get the benefits of the strength of monolithic, you do get a bit more of a polychromatic appearance, which aesthetically is obviously preferable when we're in the anterior zone. And also the translucency on Empress is very nice, and so I will only use it where the stump shade or the color of the underlying preparation is nice. If you've got a dark stump, you don't want to be using Empress Multi or Empress at all, to be honest. Sorry, one thing I should have said, guys, if anyone has any questions, feel free to fire them in the box that should hopefully be in front of you, and I will answer all of those at the end because I can't see them right now. So this is what the restorations look like straight out of the mill. Now, as you can see, they've got this sort of chalky, unnatural appearance. They certainly don't have the luster of a natural tooth, and the value, if anything, looks a little bit high at the moment, and that's because of that surface texture not being correct. So the key thing with CEREC dentistry and the differentiating factor between a poor CEREC dentist and a good CEREC dentist, and therefore the results that they achieve, is whether or not they accept things straight out of the mill or they add that 5%, that human touch, or as Phil Reddington puts it, the human blueprint, which actually makes the restoration sing and makes it look like a natural restoration. So the way that we do that is we're going to start off by polishing the restoration. So this kit that you can see here is my CAD chairside ceramic characterization kit from Meisinger. Henry Schein sell this if anyone wants to look at getting it. And we've designed this kit to allow a very streamlined workflow for finishing restoration. So there's some diamond burrs and polishers for reshaping the restoration, then the spiral burrs for polishing, and you can control the luster very effectively. And these are great, and I use them actually for provisional restorations as well. But it's really nice to be able to control the ceramic after it's been manufactured. So this is what we do, and as I say, we go through this in the course. We're going to basically mark up the anatomy that we want to enhance, sharpen up the line angles, increase the secondary and tertiary anatomy, control the surface polish, and so we're going to use a straight diamond here, followed by a couple of the spiral polishers, and that's what the restorations look like after polish. Now you can see they look considerably better on the right-hand side compared to the left, but they're still not quite there. They're still not quite looking as harmonious with the adjacent teeth as I'd like them to be. And so we then take this down to the furnace. So down to my little makeshift lab, which is in the shed section of my practice, and we now start to stain and glaze and add a little bit more character. So we're going to add a bit more blue on these restorations around the incised ledge. We're going to add a bit more chroma to the neck, and we're going to add a little bit of hypo-opacity on the incised ledges here as well to try and replicate the adjacent lateral incisors. So we put that into the Programmat CS2 furnace from Ivoclar, and then this is the whole workflow. So from start through dismantling, preparation, scan, and then finally the final restorations seated. So there you can see the restorations immediately after insert. You can see that aesthetically they look very, very nice. They do have this white hypoopacity, which is in keeping with the adjacent lateral incisors. The translucency on the incisor ledge looks really nice. The chroma, the value, all of them, I think, from my point of view, look spot on. And don't forget, this is immediately at insertion. So you may be concerned that there's a black triangle here. Now, I've taken a pre-scan papilla position, which means that I know that the papilla will, once the retraction cord retraction has subsided, the papilla will drop down into that space. So you can see here, not straight out of the mill dentistry, but what we call bespoke hand-finished chairside restorations. So what I'm not willing to accept is the efficiency of the CEREC machine, meaning that I'm happy delivering inferior quality product. What I want to be able to achieve is a beautiful product, but provided for the patient on the same day. This took around about 3 hours, start to finish, and without any physical impressions, and therefore a much more enjoyable procedure for the patient compared to how it would have been done traditionally. So there they are from the side angle. Now, as I say, this black triangle you may have concerns about when the restorations are first fitted, but as long as you follow correct parameters, and obviously we can talk about Tarnow's law of bone crest height to papilla position and that sort of thing, but you can see here the 1 month control, and that papilla has already started to drop down, and it will mature a lot more over the coming months and years into that space. So there you see Michelle before and after, a very aesthetically demanding patient, a really, really lovely patient, but with the right skills, you're able to use CEREC and use chairside restorations to deliver for these patients in the most advanced of aesthetic zones, being the central incisors. So are traditional impression stays numbered? I think I've probably already answered this. Normally when I lecture in person and not over the internet, I'll ask for a show of hands as to who has written a handwritten note in the last week. Feel free to put your hands up at home if you have done. But the answer is normally probably less than 1% of the crowd, whereas those who have sent an email is normally everyone. And I think that really is what we're going to see with the movement from analog to digital in dentistry. These are the sort of workflows for the lab-based digital workflow, and you can see how fewer steps there are there. Fewer steps naturally will mean fewer areas for error. And the really important thing here, I always look for stress minimization in my day-to-day work. One of the most annoying and stressful situations is when you get that call from your technician telling you that your impression is not good enough, or they can't see the margin, or for whatever reason, you're going to have to get this patient back in to take another impression. So you then have to call up the patient and say, "Hi, Mrs. Jones. Unfortunately, your laboratory technician has ruined the amazing impression that I took." Obviously, I joke, but you have to get the patient back in and then numb them up again, take the temporary off, take a new impression. Hopefully, this time you get the level of accuracy that you need. Temporary back on, send that off to the lab, and it's a really unpleasant procedure for the dentist, the patient, and the technician, because it puts a lot of stress on everyone. So with the digital workflow, the beauty of it is, if you have a good relationship with your laboratory, even if you're not making these chairside, once you've sent the scan over to them, you can keep the patient in the chair without the temporary put back on. The technician can validate that they've got the information that they need while you're still there with the patient. And then you know that there's not going to be any recourse on that, and you can put the temporaries on and have confidence that the restorations will be back. Normally, when you're working digitally, within 3 or 4 days, so it tends to be a bit faster. So the answer to this, obviously, in my practice is yes, I don't really take impressions anymore, and I don't miss them, to be honest with you. But definitely with the prime scan, because it is so much faster, it's so much more accurate, and most importantly, across the arch. So for full arch implant work, you can now do this with prime scan. Has a very, very good depth of scan. So even scanning into an immediate extraction socket or down into an implant fixture head, as you'll see later on, it's very, very accurate. And that's really allowed me to implement what I've always wanted, which is to be fully digital. And what I mean by that is using scans for absolutely everything. Anything from as simple as taking what used to be an alginate for a whitening tray, I will now always use a digital scan. Everything up to full arch implant restorations, which you can now scan for with the correct technicians and the correct sort of implant systems that are fully digitized. But this is where I think it's really going to have an impact on day-to-day dentistry. I think scanning should, in my opinion, become an integral part of every routine checkup. And there's a number of different reasons for that. If you look at this scan, you're getting so much information from this scan. You're getting information that there's a little chipped tooth up here on the upper right 6, the position of these imbricated upper incisors, a breaking down amalgam with a little bit of secondary decay, a chip on the tooth behind. Now, you may chart this down with your traditional x-rays and your photographs, but to have that digital scan, it's so much more live and it's saved digitally, which is beautiful. And I'll explain why that's important later on. But these three things, I think, are now the gold standard for a dental examination, and allow you to really look after your patient in a far more comprehensive way. So for me, I would view this at some point in the future, I don't know when it would be, but certainly in combination with artificial intelligence coming into X-ray reading, the traditional chart that we were all taught, and I know that we all do this on software now, but we're still in essence doing the same technique. I think that this intraoral scan will eventually take over that, because this is so much quicker, more efficient, and more accurate than doing it in the traditional way. So that's one benefit of doing a scan on every patient. The other benefits are that obviously you now have a database of your patients, which means that if, heaven forbid, they ever have an injury and smash their front teeth, you actually have a replica that you can copy straight into the definitive ceramic restoration, or even 3D print the original model and use that to guide a composite restoration, which gives you a far higher level of accuracy with regards to the occlusion and also the aesthetics. The other thing you can look at is actually how the patient is developing over the years. Now, monitoring is something that I'm not a massive fan of. I feel like it's something that we do in dentistry, but maybe we don't do it quite so much in medicine. And sort of monitoring just says to me that we're leading things to get worse. But sometimes patients will not want to move ahead with treatment at that point, understandably for financial or whatever reasons. And having software like this, and this is the AuraCheck software from Dental by Sirona, having software like this allows us to actually overlay the position of the teeth, the condition of the teeth, and therefore illustrate to the patient in a very direct way that the wear, for example, is getting worse in their teeth. I'm sure you all have patients that swear blind, they don't grind their teeth. And you can quite clearly see that they do. So you can monitor this wear, you can monitor gum recession and see if it's actually getting any worse. And you can also monitor tooth movement. And if you're looking at sort of lower incisors and they're already crowded, and you take a scan and then 2 years later you can show the patient that it is physically getting worse, then all of these just give you a level of trust and a level of sort of ammunition to come to your patient and recommend whatever you think is going to be best for their dental health moving forward, and illustrate it in a way that hopefully they understand as well. So these are the things I think are going to become more and more usable and practical as the technology and the software develops. Now, as I said, I have brought digital recently into my hygiene team's armamentarium. This bit of kit, the Airflow Prophylaxis Master, it really is fantastic. So in essence, what you have here, you've got an air polisher here, and they've done a lot of research into the particles, the erythritol that they use to clean with, and the scanning electron microscopy studies are amazing at showing that it really, firstly, the damage that the traditional way of doing things can do with ultrasonics, depending on which ones you're using, but also that with this powder, it actually doesn't damage the teeth at all, and it is so much more effective at cleaning away biofilm and therefore bringing our patients' gum health right up. And my hygiene team have really been impressed, firstly with the aesthetic result of the stain removal, but more importantly, how easy it is for them to clean into difficult areas such as imbricated lower incisors, and also around implants as well. And we do a lot of implant work, which is traditionally, I feel like hygienists, through no fault of their own, but the research is a bit mixed. They worry about cleaning around implants, and with the Airflow you can do it very, very effectively, but also atraumatically, which is great. And the ultrasonic tip that they have here, again, looking at technology, they put a lot of research into this piece-on ultrasonic, and they call it pain-free technology, and it even has a resistance assessment within the tip, so that if you push too hard, it'll turn the resistance down, or if it feels that it's got more calculus to get to, it'll ramp the resistance up. So it's very, very clever, and speaking from personal experience, it's actually considerably more comfortable than the traditional way of doing things. So, as I say, my patients have been loving it. We've got 3 of these units in my practice now, and it's one of those things that when you make the jump which can be quite scary at first, you don't tend to go backwards from that point. So that's great. And the other area of oral hygiene where technology is having a big impact is obviously with electric brushes. So I've been using Oral-B brushes for a number of years now. If you've been stuck at home watching Channel 4, you may have seen my face pop up on their TV advert at the moment. But they've recently launched their IO toothbrush. Now, the reason that I love Oral-B toothbrushes is firstly because of the evidence behind them. But secondly, it's because they are innovating in this space really, really nicely. And I think the more you can innovate, the more it can help to actually get our patients to start using electric brushes more. Now, this, as you can see on the slide here, recent studies have shown that less than half of British adults are using an electric brush. Less than 20% of adults are using an electric brush worldwide. Now, those are pretty awful statistics. And the other statistics that I've seen are also that most patients will make the decision based on what their dentist is saying. So it is up to you to try and persuade your patient to use an electric brush, because I think most of us would agree that the oral hygiene of someone using an electric brush is more effective. Now, the other thing that I love about this new brush is that they have these, not just a basic pressure sensor that shows when you're brushing too hard, but they also have a white light that flashes when you're not brushing hard enough. So it really forces the patient to brush at the exact correct force, so they don't ensue with recession or abrasion defects unnecessarily, but also they're effectively cleaning the plaque away, which is vitally important. And this does connect with the app. I've been using the app since it was the first generation, and it was a bit clunky at that point, and it was a bit impractical because you sort of had to be on your phone the whole time. I'm normally checking my Instagram when I'm brushing my teeth. Don't tell anyone. This is a much more sophisticated bit of kit. So once you set it up, it automatically records the areas where the patient is missing and how long they're spending in each of the quadrants on each surface. So I think they've got 16 zones that they record, and that information can then be outputted. And when the hygienist is having a discussion with the patient about how well they're brushing, they can then have real data to work on with their patient. So that's a really great innovation there. So let's move on to chairside restorative. I better hurry up a little bit, otherwise I'm going to keep you in here all day. So chairside restorative. So materials is something that I'm very, very passionate about. Materials is an area that is developing probably the fastest in dentistry at the moment. And these monolithic materials are getting better and better every year. And you'll see more and more clinicians start to make the move to monolithic because the aesthetics are getting up there. Now, they'll never be as good or as natural as a fully layered anterior restoration from a talented technician. But as the translucency, the chroma, the polychromaticity of these materials improves, it's going to get very, very close. And the strength of these materials is what I love about monolithic. When you have a monolithic restoration, it's very, very rare to see that restoration fracture. That's a lovely, especially when I'm using Emax, which is sort of my workhorse for most positions in the mouth. I'm touch wood yet to have an Emax monolithic restoration break on me. But as you can see here, we've got a number of different categories. So for monolithic ceramics, I tend to stay in the middle here of using Empress Multi, Emax CAD, or Celtra Duo. For posterior restorations, inlay, onlay, those sort of things, I tend to use either Tetric CAD or Enamic. Implant restorations, I do a lot of provisionals on implant restorations using Telio CAD and CAD-Temp, and I use Emax monolithic restorations as well. And then you've got some big provisional block restorations down here as well. So let's talk about the sort of the classic CEREC restoration, a single posterior restoration such as this. You can see a heavily broken down upper right 6 here, big MOD amalgam, already been patched up on the mediabuccal cusp, and actually had secondary decay underneath it as well. So we have elected here to provide the patient with a indirect restoration. You can see there this cusp tip has a nice wide base. It's more than 1.5 millimeters in horizontal dimension. And so that's the decision-making process that I've made to decide to keep that cusp instead of actually covering it. Okay, so I just put my perio probe horizontally across that, measure it. Is it more than 1.5 millimeters? After I've done my preparation, And if the answer is yes, then I'm going to retain it in a vital tooth. So as you can see, rubber dam preparation here, prepared it for an onlay. We then scanned the patient in, designed the restoration. Rubber dam goes back on again for the bonding process using the Adhese Universal bond here with Variolink aesthetic. And then you can see the final restoration, which is an Emax CAD low translucency restoration in position. And you can see really nice staining and glazing here just to try and create a three-dimensional restoration that looks like nature. And there you can see the post-operative situation after bonding on the day of fit. So as you can see, if I got that back from my technician, I'd be very happy with that. It takes around 2 hours to achieve a restoration that looks like that. As I say, these restorations last incredibly well. Now, there aren't really any locations in the mouth that I don't feel comfortable using monolithic Emax. Even on a 7 in a parafunctional patient, as long as the preparation is correct, as long as the bonding protocols are correct, I've got no issues with minimally invasive Emax onlays in any location in the mouth. And that's sort of supported by this meta-analysis that I like to discuss. This is a meta-analysis by Hickel and Manhart from 2006, I believe it was. It's quite an old study now, but it was looking at CAD/CAM ceramic restorations as an annual relative loss rate for posterior restorations against other materials. And you can see that it drops in here below gold, which obviously most of us would agree would be the gold standard posterior restoration. And it's a long way better than traditionally made ceramic restorations with the lost wax technique. So that's very reassuring that these restorations, as I have seen anecdotally in the 7-8 years of my career, actually last very, very well when the correct parameters are maintained. So let's have a look at another posterior restoration here. Here you can see a failing posterior DO composite, and we're going to replace this with again another Emax onlay. It's more of a sort of a crown lay, this one. We had to break this mesial contact. You can see the remnants of what was a carious restoration, a carious lesion in the mesial there. So in this case, and this is my sort of gold standard now, what I'm going to do is actually scan the patient in with the rubber dam still on. So we scan the patient preoperatively. That gives us enough reference points to stitch everything together. And then we scan the patient in under rubber dam, and that gives us the best isolation and tissue control for making sure those margins are super, super crisp. So Dentist by Sirona in their latest software have discussed this 5-click concept. And what that basically means is they're trying to get you from start to finish, from scan to mill, in the software within 5 clicks. And the beauty of it is that because it's built on artificial intelligence, every restoration that's made with this software, it's more and more data for the artificial intelligence to learn from. So it's getting better and better, and it's meaning that you have to do less steps. So steps like drawing out where the margin is, the software actually does that for you now, and it's doing it better and better every year. But scanning under rubber dam and having correct preparations and having good scanning, all of these sort of basic principles are very important. So here you can see the pre-op situation, and there is the post-op ceramic restoration. Again, just sort of a bog standard Emax onlay restoration, which again, I have no doubt will last very, very well for the patient. Similar sort of thing here with this premolar. As you can see, very, very minimal prep here, minimal onlay preparation. People tend to be a little nervous about leaving the margin mid-buccal in premolars, understandably, because it is part of the aesthetic zone in essence. Again, we've scanned here under rubber dam. We've used a high translucency ingot here, so a high translucency CAD block. And by doing that, and by using a tooth-colored, in this case, a Variolink aesthetic dual cure resin cement, by using a colored one, we can actually create a beautiful blend on the margin here. So you can see, you really can't see where that margin is. That's by using, as I say, a high translucency Emax in combination with a tooth-colored resin cement, and you will, if you polish it up nicely, get that sort of lovely blend no matter where you put it. And that's the beauty of these materials. Now, quadrant dentistry is an area where CEREC really sings. It works fantastically well. From a productivity point of view, it works very well for your practice. and it allows you to deliver really high-end, high-quality restorations in a single visit for your patient. And you can see what I would call a sort of a very old-school British quadrant here, very heavily broken down situation. This has been recently re-root treated by an endodontist and provisionalized in that state. You can see a very heavily broken down old amalgam restorations here, caries all over the place. We need to rehabilitate this quadrant for the patient. And traditionally, this would be done obviously over 2-3 weeks while the restorations were manufactured. But in this sort of scenario, we can make this for the patient within a matter of around 3.5 hours, something like that, but not compromising on the quality at all. And I think certainly, and this is sort of a side note regarding COVID, being able to provide services to your patients while minimizing the number of visits they have to make to come and see you will, I believe, become more and more important as we move forward. I think the aim will always be now, certainly for the next few months, maybe years, to minimize the exposure that your patient has to have, and that you have to have to your patient. And I think by providing these restorations same day, they only have to come to the clinic once, and therefore you're reducing their potential exposure to these things. So that's potentially how digital may have an impact here. So here are your restorations. Unfortunately, full coverage, because of the extent of the breakdown, the patient had buccal carious lesions on both 6 and 7, as well as obviously heavy breakdown. We've rebuilt the cores with composite here prior to scanning the patient in. And then this is how the restorations come out of the mill, so in a lithium monosilicate phase. And then once they are crystallized in the furnace, with a sort of 3D stain and glaze technique, they come out as lithium disilicate, which is much harder and ready for purpose. About 380, I think 400 even maybe megapascals of strength in those. And here's your before and after. So as you can see, aesthetically, very happy with those restorations. Patient was thrilled. As you can see, a really nice aesthetic improvement for the patient. Again, functionally, no worries about these lasting for a very long time. Now, as I said earlier, I do like to use some indirect composite, and I tend to use this for biomimetic reasons. And I'll show you what I mean by that here. So when you're retaining a cusp and you're leaving cusps exposed into the occlusion, you're in essence allowing a certain amount of flexion of that too. So the dentine supporting the enamel will be flexing, and those cusps will be flexing when they're loaded. Now, if you use a material such as Emax in these sort of scenarios, what you're going to find is the Emax is not going to flex because it's very hard, and it doesn't have a particularly flexible modulus of elasticity. But the tooth is going to flex, and obviously that differential between flexing and not flexing is going to lead to an opening up of the margin, an increase in staining, and eventually moisture uptake and caries forming at those margins. So by using an indirect composite, which has a modulus of elasticity which is more similar to that of dentine. So you can see here 30 GPa for enamic and 19 GPa for dentine is significantly closer than for glass ceramic 96 GPa, which is obviously a little bit more close to enamel. So when I'm doing full coverage, onlay, crown lay, crown, whatever it is, I'm more than happy using glass ceramic. But I've tended to move more towards using either a hybrid such as enamic or a full indirect composite such as tetric CAD for these sort of inlay-onlay restorations, and they work very well. The other benefit of using these sort of materials is that you get a lot more mills out of a single set of burrs, and you can mill them very fine with a high level of accuracy. So you can see down to 0.3 here, the edge stability of enamic is very good, whereas Emax and even Empress show more chipping when you thin those margins right down. And that is a problem with lithium disilicate, and that's why sometimes you have to bulk up the margin and then polish it back in its purple phase intra-orally before you glaze it. And the other benefit of these materials is that they're very favorable against the antagonist. So they have a wear resistance which is more akin to a natural tooth, and so you don't see quite such heavy abrasion against the opposing dentition. So in wear cases, for example, if you're going to do Francesca Valiati's 3-step technique, where she'll do a palatal indirect composite veneer and a labial porcelain veneer, they're very good for that scenario because the patient is going to wear against those palatals of the upper anteriors regardless of what you do. And so to have a material which is kinder to the opposing dentition will provide your patient with a better long-term success rate and scenario for their lower anteriors. So here's an example of a tetric CAD case. As you can see, obviously, taking out the old amalgam, taking out the caries, retaining as much enamel and tooth structure as we can do, bonding the restorations in under rubber dam, and there you can see the definitive restorations in position. Now, they're not going to win any awards for aesthetic case of the year, but they look perfectly satisfactory. They look like natural teeth. The patient is thrilled, but most importantly, they're going to have a really nice, long-lasting restoration there, which I would say would be significantly superior to doing this either in a glass ceramic or doing it in a direct composite format. That sort of volume of tooth loss, and when you're missing sort of a whole cusp here and a large amount of the tooth structure on the premolar as well, when I'm missing that much tooth structure, I would do it in direct composite if budget forced the patient into that position, but I will offer them an indirect option because I view that it will give the patient a significantly improved longevity. So let's move into the anterior zone now. And there's a lot of CEREC dentists out there who aren't using CEREC for anterior restorations. And the reason for that is that they view that they can't achieve the aesthetics that they desire for their patients. Now, case selection is vital here. There are certain cases that I will still send back to my laboratory technician. If the stump is a very, very dark color, if I've got some teeth which have got a dark stump and some teeth with a light stump, those are very, very difficult to manage with one monolithic chair-side block. However, I'm going to show you a number of different cases here in the anterior zone where aesthetically we've achieved a very nice result. And one of these restorations on the screen here is a CEREC restoration, even in a single central location where we can achieve beautiful aesthetics for our patients. So let's start with Daniel. Now, Daniel is what I call the fully digital patient. We've done everything on Daniel from indirect to direct to some Invisalign, replacing his upper left 4 with an implant, guided, restored with CEREC, and it's all been done using digital scans. So he came to me with these big provisionals on his central here post-endo. All the front 4 incisors have had root canal treatment carried out. And we're going to start this off with a bit of facially generated treatment planning, some digital smile design, and then we're going to crack on with some Invisalign orthodontics. So we scan the patient in, we deal with the sort of collapsing of the jaw, deal with the deep bite, and get the patient restoratively into a much better position. Now, I'm a massive fan of pre-restorative orthodontic treatment, whether that's Invisalign, if it's a straightforward case like this with me, or whether that's traditional orthodontics with my orthodontist. Getting the teeth in the correct position prior to doing any sort of restorative work is absolutely vital for the long-term prognosis of your restorations. If you look at this deep bite, and he has a very crowded lower anterior zone here, the prognosis of these upper 4 restorations that I'm going to provide for the patient are going to be dramatically improved by having a nice aligned lower anterior section. And I see so many upper 5 to 5 aesthetic cases carried out with no regard for the lower anteriors, and that is short-term treatment planning as far as I'm concerned. And I very much prescribe to Miguel Stanley's no half smiles philosophy on this, where actually you need to be looking at the whole mouth, because thinking short-term and just sort of smile zone treatment is not good cosmetic dentistry. So this is the post-ortho position of the teeth. We scan the patient in again after 8 months of Invisalign and send the intra-oral scan with the photos over to Phil Reddington at Beaver Dental Technology. He creates this beautiful 3D wax up for us, sends the STL file back to me by email, and then I can 3D print that on my Formlabs printer. So you can see it's recreated this lovely anatomy that Phil has painstakingly put into the STL file. And we're now going to do what I call a cyborg biocopy. So you can see this is on the Omnicam. This is an older case here. But basically what we do is we scan in the patient's upper jaw, we cut out the area that we're going to be changing, and we scan in the 3D wax up. So by doing this, we can use a technician's beautiful eye for shapes and primary and secondary morphology, but we can create the restorations chairside on the same day for the patient. So it's a lovely mix of digital and or chairside and lab techniques, which I think works really, really well. So we scan the patient in there, and we then use that using what's called a biocopy or a biogeneric copy to copy that into the proposal. So the software copies Phil's wax up, and we can then mill those restorations out of Empress Multi again. So there you can see the final restorations in position. Unfortunately, the patient had a bit of perio, so again we've had a retraction of the papilla here after periodontal treatment. But you can see a beautiful aesthetic improvement for the patient there. Obviously, they've done a bit of whitening as well. And what I really love is this shot here. So you can see that anatomy that Phil's built into the incised ledges. You can see the gradation of chroma and translucency through the block. And these are just hand polished. These aren't staining glazed at all in this case. But you've got a really lovely luster to the teeth, a very natural looking aesthetic outcome on a relatively difficult case. And again, all those ceramic restorations were provided in a single visit for the patient. Now, the other thing that I really like to do is to use materials which may be different in properties, but contain similar optical properties that allow for a beautifully aesthetic but minimally invasive result. So what I tend to use for this is Empress Direct Composite, which is my go-to for cosmetic bonding and anterior cases, and then Empress Multi, which you've seen in a number of the cases already. And because these are made by the same manufacturer and they're both Empress, they have very, very similar optical properties. And by being able to finish the ceramic and the composite both chairside, I can get the luster of the restorations to look exactly the same. So this is Brini. Brini is a Instagram influencer. She came to see me unhappy with the appearance of her anterior teeth, diastemas in between upper and lower 4 to 4, and an old ceramic veneer on the upper right one with a dark non-vital tooth. The frenal piercing is not my doing. But Brini is an absolute superstar, and she travelled all the way over from East London to come and see us. And the treatment plan for her was to carry out some whitening. She didn't want porcelain veneers on all of her teeth. She didn't want any orthodontic treatment. So we elected to do cosmetic bonding to close down these diastemas and achieve an aesthetic outcome, whilst also replacing the veneer on the upper right one and doing some internal and external tooth whitening. So we did a quick mock-up just to ensure that widening the teeth wasn't going to look odd in the patient's face. We then did some internal whitening on upper right one. So for those of you that aren't aware of the walking bleach technique, this is very, very predictable. I use Vitrabond placed on a perio probe, a ball-ended perio probe, down to seal the root canal space, take the GP down to below the CEJ level. Very, very predictable technique for improving the colour of non-vital anterior teeth, a procedure that I absolutely love to do. So the patient puts the gel in there, 6% hydrogen peroxide, turns it over every hour for 4 days, and then she comes back with a much better stump colour for us to work on. So we then measure up the width here and then get about doing the cosmetic bonding. So here you can see the patient has that mock-up still on the veneer. We're doing cosmetic bonding upper 4 to 4, and because the patient's travelled from the other side of town, we're actually doing all of this on one day. So we're doing 13 units of cosmetic bonding and 1 porcelain veneer, and we're only seeing Brini for the whole day. So quite a lot of work. So here you can see the cosmetic bonding has been roughly placed. We've still got to finish this, but we're going to get the restoration milling while we're doing the final polishing on the bonding. So there you can see our final veneer prep. Obviously this was already a veneer, so the preparation had already been done and it was relatively invasive. So we basically just polished that up, smoothed it all off, and scanned the patient in for a porcelain veneer, which again is going to be Empress Multi. And then here is the patient's before and after. So again, this was at the review, but this was all done in a single visit for the patient. And the key thing here is that you will struggle to be able to see where there is a ceramic restoration and where there is a direct composite restoration. And that's the key thing here. And that's because I'm doing everything chairside, I can not over glaze or over polish the ceramic restoration, which is this one here, and I can also polish up the composites to the same level. For those of you that do a lot of composite veneers or edge bonding, the Diatec polishers from Coltine, I think, that sell them are really, really effective for polishing, and Empress Direct polishes absolutely beautifully. So here you can see Brini. She, as I said, she is an Instagram
Hey guys, welcome back to my channel.
and YouTube blogger.
Well, so in this video, I want to basically tell you guys.
And as you can see here, when I made this slide, it had 212,000 views. This video, it's now had about 250,000. And I still get new patients through the door on, well, not at the moment, but normally on a daily basis who have seen Brini's video. So I can't speak highly enough about working with influencers to help with your business as we get back to work. Yeah, as you can see, quite a change for Brini here, both in the hair as well as the teeth location. So this is Grace. Grace actually came in after seeing Brini's video, and it's a relatively similar case. We're doing a hybrid direct, indirect here. Grace has already got a ceramic crown on her upper right too. And in this case, the patient did decline to have any alignment of the lower anterior teeth done. Now, that was a shame for me, but she was offered the option and she declined it in this specific scenario. So in this case, this has been printed on my photon printer. So that's that £400 printer that I showed you before. And we've got a digital wax up done here, which is going to guide the bonding. So as you can see here, it's going to guide the position of the direct composite buildup. And it's also going to be used in a similar way to Daniel's case as a cyborg biocopy to guide the ceramic manufacture. And there you can see the Empress the Empress multi crown being fitted. And here you can see Grace's before and after. And there you see, again, a really nice aesthetic result, again, provided for the patient on the same day, and all guided off that 3D wax up, which has been 3D printed. And there's the close-up again. So again, luster control, really, really important for getting a nice aesthetic result in these cases. Now, this is a very interesting case, and I believe I was the first person in the UK to do this. I've seen a couple of guys do it across the world. I saw Gerard Whirling doing it first. It's a really interesting concept. So there's been a lot of evidence done by Pascal Magnier and actually Daniel Edelhoff and their group on the best materials for cores, the best materials for posts. Are posts required anymore? I saw a really interesting webinar with Pascal Magnier recently, where in essence he's saying posts aren't required anymore. They don't offer any significant benefit in any location when correct protocols of adhesion are carried out. And that's really interesting. And I haven't followed that concept here, but I have used what they recommend, which is using a indirect core, or a high performance polymer in this case, for longevity of badly broken down anterior restorations. So here you can see Chris. Chris, as you can see, has 4 ceramic restorations on his anterior teeth. They've all got periapical, 3 of them have got periapical lesions underneath them. They've all got caries underneath them, and aesthetically, they're not looking fantastic. Now, as you can see, once we dismantle these teeth, and I always take an extra appointment to dismantle teeth first, and that's something, especially for young dentists who might be quite keen just to rush into things and try and deliver restorations for patients really quick. Even though I can provide my restorations on the same day for patients, I don't always choose to do so. And in this sort of case where I don't really know what I'm going to find under these old restorations, it's a good idea to slow things down, take the time, dismantle, and then have the discussion with the patient about the definitive treatment plan after you've actually dismantled the old dentistry. So as you can see here, we've got very little ferrule remaining on these central teeth following the removal of the old posts and the old restorations. So I've had a discussion with the patient at this point, especially with regards to upper right 1. Do you want to consider crown lengthening surgery? Do you want to consider implant surgery with the loss of the teeth? Do you want to consider bridges, etc.? The patient wanted to retain his natural teeth without any surgery for as long as possible. Patient's prerogative to make that decision, and he's consented for the fact that both these central incisors have a guarded prognosis moving forward, especially upper right one. So anyway, what we're going to do is carry out a root canal treatment, or my root canal doctor, Dr. Noman Atwal, is going to carry out root canal treatment on upper right one, upper left one, and upper left two. The root canal and post and core on upper right two was in very good condition. It was a very long post, and we elected, again in conversation with Noman, to actually leave that one as it was. And I'll show you how I deal with the aesthetic implication of that in a second. So as you can see here, what we're doing on the right-hand side of the screen is we are using the ultrasonic instrumentation from Comet. So this is an ultrasonic diamond burr, which is very, very good for refining preps. But in this case, I'm using it for refining the internal post space so that it's nice and smooth, and so that I can actually scan it into my prime scan. So here you can see, and the first time I saw this, I thought it was absolutely incredible. A scan all the way, and you can see a really, really accurate scan all the way to the base of that post space. So what I'm doing here is I've scanned in the internal pulp chamber space and the root canal system, and I'm now going to design my one-piece post and cores. So here's the design. You can see again scanned in under rubber dam. The posts and cores are designed, and they're actually milled here out of, again, a biomimetic material. What am I replacing? I'm replacing dentine. What am I going to use to replace this post and core? A material that has a modulus of elasticity as close to dentine as possible. And that for me is enamic. So again, that is a ceramic composite hybrid material, which is milled out of a solid block, and we can then bond those restorations in. Now, they did not require any adjustment whatsoever. They are obviously completely bespoke to the internal space of these roots, and the beauty of that is we keep the resin thickness down to an absolute minimum, so we really are looking at giving this patient the best chance of long-term survival of these teeth. We bond those in under rubber dam. You can see that we've masked the metal post on the upper right too, and we've done that using the ASC technique, so air abrasion, silination, and then pink composite opaca from Cosmedent, which pink is on the opposite end of grey on the spectrum, and so it blocks out that grey colour very, very effectively. So we now have three teeth which are close enough in shade that I can mask this with a monolithic low translucency EMAC restoration. So we scan the patient in again, we design the restorations, we stain and glaze them, and they're now ready to be fitted. And here you can see the final restorations immediately after insertion. Again, always focusing on the surface texture, the primary, secondary, and tertiary anatomy. And you can see at the necks of the teeth here how I've increased the chroma. You can see that on the canines as well, a bit of staining there. So we've tried to really create beautiful aesthetics for the patient here. It's a dramatically improved aesthetic result. I would have preferred to see some longer centrals, to be honest with you, compared to the gum position on the laterals. So that is a compromise. And we've also built up the canine tips with some composite to protect these teeth in lateral excursion, because you can see that the canine tips have both got some wear facets on them there. So we're trying to keep the protrusive and excursive movements off these central two teeth, which we know have got a guarded prognosis. But as you can see, a really interesting way to consider that sort of solution to avoid using a stock fiber post with a large amount of composite material, or using an indirect metal post, where obviously the modulus of elasticity is a long way away from the material that it's replacing, and naturally you're going to see an increased chance of fracture of the root. It's also not adhesively cemented into the teeth, and so it has limitations in that regard as well. So let's move on to the really advanced stuff here, which is doing a full arch of restorations using chairside restorative. Okay, so again, all of these restorations are going to be made chairside. You can see another post-perio case here where the patient has had periodontal treatment done by Dr. George, and she's then going to have some orthodontic treatment to align her lower anteriors and try and bring these centrals a little closer together, and then we're going to replace all of the upper restorations with new, more aesthetic ceramic restorations. And there you can see it, as you can see, a heavy breakdown of these anteriors and a sort of collapsing in of the lower arch and a protrusion of the lower right one. So again, alignment of these teeth is going to help with the prognosis. We're also going to pop an implant in lower right 6th location. So 4 months of Invisalign, just to improve the position of the teeth prior to restorative work. We then dismantle the old dentistry and tidy up the preparations. Again, we're using the ASC technique to mask the lump on that upper right, on the upper left one, sorry. Oh, that's just frozen, sorry. Give me a second here. Technical difficulties.
Hi everybody. Hopefully you can hear me. I think Simon has had a bit of a technical issue with his mic. I am trying to get hold of him. If you can all please be patient, shouldn't be much longer, and we'll try and get back on track. Thank you. Hi everybody. I'm terribly sorry about this. Unfortunately, I'm unable to get hold of Simon, so I think he has a problem with his internet. We have got all your questions that you've asked, and I'll happily forward these on to him and get him to reply to you personally. Thank you for watching, and apologies once again.